to be implanted within 6 hours.
Hi, we have just learned about the different types of trauma. In this next video, we will see how a mountain man from West Virginia decides to dish out a little trauma of his own when his eggs don't come out just right. Thank you.
So I held that butcher knife up to her neck and I said, "Woman, if you want to live to see tomorrow, you better start frying up them eggs better than you've been frying them. I'm tired of eating them slimy, sloppy eggs. Now get in there and fry me some eggs. I love you, baby." Them eggs better be cooked right now. I want your cigarette. Woman, these eggs better not be slimy, sloppy eggs.
Anesthesia plays an important role in trauma. The anesthesia provider is a critical member of the trauma team. They must be available 24 hours a day. They must be able to take care of severely traumatized patients from the moment they arrive to the trauma center. Anesthesia can directly affect the survival of trauma patients, and anesthesia is primarily concerned with the management of the airway and ventilation during the initial resuscitation efforts. The initial assessment of the trauma patient can be divided into primary, secondary. Bleeding from the extremities is easily controlled with pressure dressings and packs. Tourniquets can cause reperfusion injuries. Pneumatic anti-shock garments can decrease bleeding in the abdomen and lower extremities, increase peripheral vascular resistance, and augment perfusion of the heart and brain. Bleeding wounds above the level of the suit can contraindicate the use of these garments because of the risk of increased hemorrhaging. The term shock denotes circulatory failure leading to inadequate vital organ perfusion and oxygen delivery. Although there are many causes of shock in the trauma patient, it is usually due to hypovolemia. Physiological responses to hemorrhage range from tachycardia, poor capillary perfusion, and a decrease in pulse pressure to hypotension, tachypnea, and delirium. Serum hematocrit and hemoglobin concentrations are often not accurate indicators of acute blood loss. The hemodynamic liability of these patients demands invasive arterial blood pressure monitoring. The degree of hypotension on presentation to the emergency room and operating room correlates strongly with the mortality rate. The mainstay of therapy of hemorrhagic shock is intravenous fluid resuscitation and transfusion.
Fluid resuscitation is an important aspect of the care of the trauma patient. Anesthesia, how's that fluid resuscitation coming? Almost there.
The choice of initial fluid therapy is determined primarily by availability. Although fully cross-matched whole blood is ideal, typing and cross-matching take 45 to 60 minutes. Type-specific blood may cause minor antibody reactions, but is appropriate therapy as soon as it is available. Uncrossed O-negative packed red blood cells should be reserved for life-threatening blood loss that cannot be adequately replaced by other fluids. Crystalloid solutions are readily available and inexpensive. Resuscitation requires large quantities. However, because most crystalloid solutions does not remain in the intravascular compartment, lactated ringers injection is less likely to cause hypochloremic acidosis than is normal saline, although calcium in the former makes it less compatible with blood transfusions. Should crystalloids or colloid infusions constitute the mainstay of fluid resuscitation in trauma? The debate over which solution should be used for resuscitation is ongoing and controversial, owing to conflicting data whether one has improved outcomes versus the other. Colloid solutions contain large molecules that remain in the intravascular compartment longer. This osmotic effect results in less volume shift into the interstitial fluid. Because of this, fluid resuscitation with colloids is purposely more rapid and effective. Colloid solutions are expensive, however, and some solutions can contribute to coagulopathy. Larger volumes of crystalloid solutions are needed for intravascular volume resuscitation in trauma patients because the fluid is rapidly redistributed to the interstitial space. This may contribute to the development of tissue and pulmonary edema. Advantages of crystalloids are that they are inexpensive and cause few adverse reactions. The use of both solutions is often advocated to restore intravascular volume, but until definitive data exists to support a specific fluid therapy regimen, the debate will continue. Whichever fluid is chosen, it must be warmed prior to administration. Rapid infusion systems that use large bore tubing and rapidly warm fluids are invaluable during massive transfusions. A convection-forced air warming blanket and heated humidifier will also help maintain body temperature. Hypothermia worsens acid-base disorders, coagulopathy, and myocardial dysfunctions. Hypotension in patients with hypovolemic shock should be aggressively treated with intravenous fluids and blood products, not vasopressors, unless there's a profound hypotension that is unresponsive to fluid therapy, coexisting cardiogenic shock, or cardiac arrest. Clinical classification of shock include mild, moderate, and severe.
Hello. I'd like to thank you all for joining us for Anesthesia 101 of the trauma patient. I will go over a quick review. Trauma care is an important area in anesthesia practice. The SRNA involvement begins as soon as the patient reaches the trauma facility. The major concern for SRNAs is evaluation of the airway and maintenance of ventilation until intubation can be performed. The principles of successful management of the trauma patient are based on organization and preparation, assessment of injuries, achievement of a patent airway, fluid resuscitation, correction of acid base and electrolyte disturbances, careful titration of anesthesia agents. I am Dr. Blackwell. We would like to thank you for joining us. See ya, suckers. Thank you.